Hi, this is Elliot Fishman, and welcome to our latest series of lectures. This is going to be on pancreatic cancer, and I'm going to call the state-of-the-art 2020-2021. Now, pancreatic adenocarcinoma is the 12th most common cancer in the United States. However, when you look at in terms of deaths, is the third leading cause of cancer-related deaths. And within the next decade, pancreatic cancer deaths, unless we change things, will likely surpass colorectal cancer as well. It's impressive the number of pancreatic cancers we are seeing in practice. It does seem, and most people will say, that the numbers are indeed going up, and we do seem to see them in the younger population. Although the death rates for most cancers have declined in the recent decades, the death rate for pancreatic cancer is actually flat to slightly increased, in large part related to the aging demographics. Over the past 4 decades, disease-specific survival has only improved marginally, with the 5-year survival rates increasing from about 4% to 7 or 8%. The lack of clinical progress in comparison with other cancers is attributable to a failure to develop novel and effective therapies. And this was an article a couple of years back by Yaber. When you look at some of the SEER data, survival, again, minimally better than it was before, just under 8%. The patients, how many patients survive 5 more years? Again, 8%. This has improved ever so slightly, but it's really still a dismal number. We talk about reasons for pancreatic cancer. We'll talk about hereditary pancreatic factors, but carcinogens, tobacco exposure, environmental tobacco exposure, occupational and job exposures, diabetes. Now, of course, we don't know if it's the new onset of diabetes that leads to pancreatic cancer, or the pancreatic cancer is already developing and that leads to diabetes. But we are seeing often a patient in their 50s or 60s with new onset diabetes with no really good reason for the diabetes, and then within 2 years or 3 years has a pancreatic cancer diagnosed. Patients with prior episodes of pancreatitis, patients with increased alcohol consumption, are all at increased risk for pancreatic cancer. The greatest risk factor, of course, is a strong family history. 10 to 15% of all pancreatic cancers are considered familial, which is defined that at least 2 affected first-degree relatives. The lifetime risk for patients with 3 or more first-degree relatives is 40%, 10% for 2 or more, and 6% for 1. So you can see that even with 1 first-degree relative, you have over a 4.6-fold increase compared to the general population. But with multiple patients, with multiple family members, the risks are extremely high. And these, of course, are some of the patients that we do screening. The CAP study is one example. This article by Lennon on the early detection of pancreatic cancer. Early detection offers the best hope for cure, but characteristics of this disease, such as lack of early clinical symptoms, make the detection difficult. Recent genetic mapping of the molecular evolution of pancreatic cancer suggests that a large window of opportunity exists for the early detection of pancreatic neoplasia, and developments in cancer genetics offer new, potentially highly specific approaches for screening. So again, the question is, can we do screening, and can screening be successful? Bert Vogelstein and Marie Lennon, Ken Kidsler, Papadopoulos have developed this blood test, which is very good for detecting early cancer, CancerSeq, which is being fast-tracked by the FDA. There's also some other biomarkers in cis fluid that proves to be very valuable. So there is a lot going on. I don't want people to think that despite the fact that there is a dismal survival and the numbers haven't changed, I think we're just one lucky break away from making things happen. Now, in terms of pancreatic cancer, one of the things that also has changed is surgery. Surgeons are much more aggressive, particularly at Hopkins. What's potentially resectable has changed. Before, any vascular involvement would essentially make you unresectable. Now, short segment vascular involvement, particularly on the venous side, they'll put grafts in. Involvement of adjacent structures, lymph nodes, are not contraindications to surgery as well. And again, the key is getting an R0 surgery or no tumor cells within 1 millimeter of the resection site. When we talk about pancreatic cancer, it depends where the tumor is located. Whipple's procedure for head of pancreas tumors, central pancreatectomy, which is rarely used, more common for neuroendocrine, distal pancreatectomy, laparoscopic distal pancreatectomy, a distal pancreatectomy with an en bloc resection of the celiac axis, which typically occurs post-chemotherapy, and radiation therapy in a patient who had celiac involvement but now has had a great response, and they need to do aggressive surgery and enucleation. Now, one of the things, of course, Appleby procedures are very aggressive surgery. Not that many places do them. The results at times can be very promising. We also know that pancreatic surgery, like much of GI surgery and GU surgery, has become laparoscopic. We can do laparoscopic Whipples and laparoscopic distal pancreatectomies, and robotic surgery is becoming more and more common. With recent advances in pancreatic imaging and surgical techniques, a distinct subset of pancreatic tumors is now called borderline resectable. So it used to be resectable and unresectable. Now there's borderline resectable, and that's typically described as encasement of a short segment of the hepatic artery with or without celiac involvement, tumor abutment of the SMA but less than 180 degrees, and short segment occlusion of the SMV, portal vein, or at the confluence. Now, one of the things about pancreatic cancer, and this is true with many cancers, is the best way to approach these patients is with a multidisciplinary conference. So we have for more than a decade met every Tuesday, radiation oncology, medical oncology, surgical oncology, radiology, pathology, nursing, looking at 8 to a dozen patients. We've been able to change the outcome of patients, in part by redoing the CT scans and being more accurate, also defining whether a patient really has pancreatic cancer, or maybe it's lymphoma, or a serous cystadenoma, or maybe it's a duodenal tumor like a GIST tumor. You can see that on review of submitted imaging and imaging performed at Hopkins, almost 19% of patients had a change in the status of their clinical stage. And that's not just a Hopkins study. There have been other studies. The specificity for malignancy of pancreatic masses identified in expert consensus was twice as high compared with the original CT report. Positive predictive value increased to 98% after expert consensus, but negative predictive value was low for both the original CT and expert consensus. So you can see that experts do make a difference, which is why multidisciplinary conferences become so important. And it's not only in pancreatic cancer, it's many other things as well. And in this article by Gerenstein, they talk about some of these factors. They also mention the number of patients with a false positive pancreatic mass was decreased from 45 to 11, especially for the 25 patients, where a third of them almost had unexpected benign disease, autoimmune pancreatitis, groove pancreatitis, focal steatosis, and the like. So again, how well you do with pancreatic cancer first becomes the key of diagnosing it early and then staging it correctly and making sure you're staging the right tumor and you're not making a false diagnosis. We've done a lot of work with pancreatic cancer at Hopkins, and when we looked at errors, one of the most common areas for errors, and other people have written similar articles, is in pancreas, missing early pancreatic cancers, misdiagnosing pancreatic cancers, missing neuroendocrine tumors, confusing things like groove pancreatitis or autoimmune pancreatitis with cancer, confusing duodenal primary tumors with cancer. The list goes on and on. Now, one of the things, of course, that becomes very important is some consensus on how to do things. There was an article a few years back where the goal was to try to figure out how they could make a report, a template, where everyone can use so you can compare outcomes from different cancer centers by everyone using the same report. Well, it became obvious when they tried to do this that it became not only important for a template to be developed with terminology that was constant and explained. But also, once you started wanting to do a template, you realized that the key thing was the protocols. That unless the protocols were consistent, you would not be able to fill out a form. And this required thin sections, it required 3D reconstructions. It is therefore essential that these patients undergo CT angiogram using a dedicated pancreatic protocol. These factors limit the ability to generate the high-quality reformatted images and 3D reconstructions that are necessary for accurate staging. This article went on to say that if you didn't do it correctly, you should repeat the study before the patient goes for surgery. So much becomes the technique. You're not going to report correctly, you're not going to stage correctly, and you're not going to manage correctly unless you have all the information. This article also was a good prototype because it went into detail how to do the studies, what phases to get, when to do specific phases, the injection rate and volume of contrast. It detailed every little feature, from arterial involvement, how we describe it, to venous involvement, how we describe it, to extrapancreatic involvement. And again, a template describing all of these different findings and then how we should report things. Now, in this article by Brooke, Structured Reporting of Pancreatic Multiphasic CT provided superior evaluation of pancreatic cancer and facilitated surgical planning. Surgeons were more confident when they reviewed structured reports. I think whether you use structured reporting or not, the most important thing is to be able to answer the questions the surgeons have. And unless you do the proper imaging, simply doing a single phase technique with thin sections is not going to answer the questions the surgeons indeed have. It's very important, however you do your studies, that the surgeons need to understand the information present, because it changes a patient from unsure regarding resectability to a definitive answer, be it yes or no. We need definitive answers. This article by Rahman a number of years ago also made the point that if you have a scan that's more than 4 weeks old and you're staging patients based on that, you could be making a mistake. If a scan's 2 months old, you might think the patient's resectable and go in, and they're not. So you need to have a study within about 4 weeks of the time of surgery. Now, in terms of study prep, 1,000 cc's of water to distend the stomach and duodenum, or at least 750. Then injecting contrast 100 to 120 ml of Omnipaque or Visipaque. I like 5 cc's per second. We like to do arterial phase at about 30 seconds and come back at venous phase approaching 70 seconds. The arterial phase is important. Now, pancreatic cancer is typically hypovascular, and neuroendocrine tumors are hypervascular. So with arterial phase imaging, we can be very specific as to the tumor type. We also can best define the vascular mapping. How do you look at the celiac and hepatic and splenic arteries in GDA? How do you look at the SMA or optimized when you do arterial phase imaging? We know that's indeed the case. We also talk about the ability to create 3D maps. 3D maps are ideal from arterial phase imaging. These vascular maps are valuable. We've been doing cinematic rendering, and I'll show you examples of that. Also, things like narrowing of the celiac axis becomes important. If you're going to take out the patient's GDA, that can be critical if flow through the GDA is what's supplying the hepatic artery. So we need to look and make sure the patient does not have narrowing of the celiac, not because of tumor, but because of median arcuate ligament. The venous phase are important for a number of reasons. Venous phase at times, adenocarcinoma shows better. We also know that we need to look at the portal vein and the SMV and splenic vein, and that's best seen on venous phase imaging. We know also that adenocarcinoma of the pancreas gets liver mets, and the liver mets are typically hypovascular and best seen on the venous phase imaging. So that indeed also becomes very, very important. Now, the role of 3D imaging goes back for more than 20 years. Rapatopoulos spoke about the predictive value of a resectable tumor was 96% compared to 70% using 3D versus not using 3D. And House at Hopkins at 4 and 16 slice scans was able to show that 3D CT was 95% accurate in determining cancer invasion of superior mesenteric vessels. It was excellent at predicting resectability and defining true tumor burden. So now what do we do? Things in some sense have changed a lot and in many ways have not changed. When we're looking for a pancreatic mass, we look for a mass. Is it the pancreas enlarged focally, for example? We look for enhancement changes. I mentioned most adenocarcinomas are hypodense. Neuroendocrine tumors are hypervascular. We look for duct transition, common duct or pancreatic duct or both. You see a dilated pancreatic duct, is there abrupt cutoff? If there's a cutoff, it means there's a tumor present. It could be a neuroendocrine tumor, but it's a tumor present. Sometimes you only see the duct cutoff, but you don't really appreciate a tumor, but the tumor has to be there. Sometimes we see mass effect on adjacent structures. We look at the enhancement. Is the mass solid or is it cystic? Is it hypo or hypervascular? We look with arterial and venous phase imaging at duct transitions. I think the ducts are better evaluated on the venous phase imaging unless there's an enhancing lesion in the duct, occasionally with a neuroendocrine tumor. We also look at the liver, which is best seen in terms of metastasis on venous phase imaging, but the arterial phase is critical for vascular mapping. And again, looking at adjacent structures. So here's a good example of a mass in the head of the pancreas. You can see the hypovascular lesion present, nicely seen. You look at the coronal views. There's the mass. You see it abuts the patient's SMV. This patient would be definitely resectable, less than a 3 centimeter mass, well defined against venous structures, but no involvement seen. Another example, here you see the differential enhancement. The distal body and tail of the pancreas are hypovascular compared to the neck and head of the pancreas. There's also a dilated duct. There's an ill-defined tumor, very nicely shown at that transition point. We look for transition points. Same thing here. There's the pancreatic atrophy, dilated duct. There's the transition point. That's the patient's tumor. So it makes it very easy to appreciate the presence of tumors. Sometimes you see little cystic areas. Often adenocarcinomas arise from IPMNs. And again, here it is when you do the reconstructed view. You see some cystic lesions again. IPMNs, the tumor arose from an IPMN. You can see this as well on the cinematic, very nicely showing you as you go from the coronals and the volume rendering to the cinematic. The changes in the texture of the cinematic, really accentuated. Here it is on the coronal 3D volume rendered with cinematic rendering, nicely showing you the extent of the tumor and its orientation. Again, multiple views. We have been using cinematic for preoperative planning, both for vascular mapping, but also for subtle tumor detection. Here it is again, some of the views of the cinematic, the celiac and SMA, relationship of splenic artery to tumor. Another example here, a hypodense lesion, body of pancreas. This is a little over 1 centimeter. It's hypodense. There's no duct dilatation, but that's a pancreatic adenocarcinoma. You can see it nicely on the coronal view as well. And again, now we see it well as we go from the coronal projection to the cinematic projection. And here it is on the cinematic views, very nicely shown in that regard. Here it is in the coronal view. So the coronal cinematic really shows you the lesion well. It's very easy to appreciate the lesion. Its definition, its extent are all nicely shown in this example. And again, I'm able to change the rendering to show the vascular mapping, but also the fact that we can pick up smaller tumors. Another example, a small tumor in the body of the pancreas, dilated pancreatic duct. There's the tumor in the body. So again, not a large mass, but there's textural changes. There's a dilated duct. You should be able to recognize that tumor. Or this case, again, a dilated pancreatic duct, transition point, there's a hypodense lesion, very nicely shown. That's an adenocarcinoma, which is circled here. Again, the coronal views can be very helpful, particularly as you track through the duct. Another example, same thing here, dilated pancreatic duct. There's the mass. There's the normal pancreas, but there's a transition here. Transitions are always concerning, and you got to be careful you're not missing a mass. That dilated duct and transition may be the earliest sign possible. Here it is in the coronal view. You nicely see the mass, and you see the dilated duct. A very easy diagnosis of pancreatic adenocarcinoma, right there. Another example, same case, just a couple more images. You see this very nicely. You see the tumor, the dilated duct. These are the cases that the patients are going to be resectable. When you have a 5-centimeter mass, it's usually too late. Subtle tumors, these are the ones you need to pick up, but these are the ones that are commonly missed. Another example, here we see a dilated pancreatic duct. There's a transition. When you look very hard, it's at the transition that we see the patient's tumor. This was 1 centimeter. These are the tumors that are curable. But again, you got to be very careful. Sometimes people just describe a dilated duct, which is stopped. There has to be a mass present. Some people will go directly to surgery. Other people will go to EUS. Again, in the cinematic, nicely showing you the pancreatic duct with the abrupt cutoff, very nicely shown here as well, with texture mapping. Now, there is an issue at times with pancreatic masses. People talk about isoattenuating pancreatic lesions. Truthfully, it's fairly uncommon. Sometimes it's hard to see a lesion, as in the case we just showed with the pancreatic duct dilated. But again, the double duct sign or a single pancreatic duct sign becomes very important. This article by Kim suggested that hypodense or isodense lesions would be present in 5% of cases. I don't think so. This article by Kaza, 10% of pancreatic cancers can appear isoattenuating. But again, you can see from here other indirect signs, dilated duct, biliary dilatation, atrophy, are all critical findings. So I'm not calling this a mass you don't see. I'm saying there's something there that tells you the mass is present, though the mass may not be well seen. Now, what else can we look at? Well, one of the most important things I mentioned is looking at duct transition. Let's do this. We've covered a lot. I've done 20 minutes. Let's take a coffee break, and let's come back in 10 minutes, and let's do part 2. I'll see you then.
If you liked what you heard here today, please make sure to hit that subscribe button and visit our website CTisus.com for lectures, quizzes, pearls, and more. Also, be sure to check out our apps that are available for free on the Apple Store. All links are in the description box below.